5 minutes to allow the attendees to join for your particular session?
No problem at all. We can wait.
Okay, thank you so much.
And good morning, Professor Sarah.
Yeah, good morning. How are you? Fine?
I'm good.
Yeah.
Dr. Suresh, before we start, I think you can also throw some light on Mr. David's question, if you have, some idea on it, that how are the doctors in Tokyo able to approve any new innovation, if possibly, until we can begin?
I guess, as in most countries, it's not directly up to any medical practitioner to approve any innovation. It's primarily the regulatory authority which has to do the approval. But relatively speaking, compared to like even 5 years, 10 years before, the university system, as Professor Sasahara mentioned, is now opening up several incubation centers and innovation centers. And as he mentioned, Tokyo Medical and Dental University has actually opened up an innovation center in 2017, which is only 3 years before.
Okay.
So through this system, they can actually field test or probably trial new ideas, and then it goes through the regulatory system, and hopefully it gets approved. So it's a process that is relatively much more streamlined compared to other countries. But otherwise, it's going through the innovation system, which is actually innovation centers which have been created up recently.
Okay, Dr. Suresh, I have one question personally, since we have some time.
Yes.
As you're aware, in India, doctors or pharma industry, for that matter, as per our personal experience, are not very receptive to innovation. It takes a lot of time. How is the situation in Tokyo? Is it the same over there? Does it take time for people to accept innovation, or are they more proactive when compared to the Indian market?
So, it's not a single statement that you can actually make that doctors are not receptive. Relatively speaking, the older generation of doctors are again relatively a bit lesser compared to the newer generation of doctors. So if you look at a doctor who is like 30 years or 40 years, whether you are in India or whether you are in Japan, they all try to say that, I use new technologies in surgery. And even if you look at India, most of these private hospitals extensively advertise new technology based surgeries or services. So the newer generation is much more receptive, because I believe they are able to understand what goes in much better. But again, you cannot say that all older generation people are not receptive to technology. Again, there are early adopters in the elderly population also. But the situation is that in countries like Japan, where technology adoption has been more prominent in the last 30 years or 40 years, you find that there are actually more people who are who believe and who support new technologies, compared to India, where relatively speaking technology adoption has been happening only in the last 5 to 10 years. So that way the proportion is slightly a bit larger there, but I guess both countries are going in the same direction now.
Okay. Thank you so much, Dr. Suresh. I would like to now introduce Dr. Suresh to our participants. Dr. Suresh Munuswamy is a medical doctor and scientist who designs and develops new technology-based health and social care solutions, especially for people living in the bottom of the social pyramid. He did his MBBS in Chennai, MPH in Oxford, and PhD in Tokyo. He was the first Indian to be selected for the Public Health Leadership Program, fully sponsored by the government of Japan. At Public Health Foundation of India, he's the head of technology innovations and coordinator for Government of India's first integrated MSc and PhD health informatics program. At PHFI IIPH Hyderabad, he's the coordinator for Health Informatics Rapid Design Lab, which was started with support from Department of Science and Technology, Government of India. where they work on graphic design, product design, computer vision, and visual analytics for healthcare. The lab is successfully developing artificial intelligence, augmented reality, computer vision, telemedicine, and geographical web-enabled health and social care services with funding from national and international grants. Thank you so much again, Dr. Suresh, for taking the time today to speak to us. I think you can now share your screen.
Just give me a second, please.
Sure.
Well, thank you, Rashmi. I hope I am audible. Thank you, Professor Sasara, for the introduction. And as you mentioned, I got into health informatics after listening to your lecture. I think it was in Temple University in Tokyo. And I guess there are some of my new students who are also listening to this lecture. So I'm passing it on, hopefully, to the newer people who will take things forward, maybe in another 5 years or hopefully 10 years. So thanks a lot. My presentation is on the role of digital healthcare, but more on the primary healthcare side, not much on the hospital side. And this is one area that India is actually focused heavily on, but with relatively limited results. So one of the reasons why my lab was started in 2013 is to come out with a digital platform for primary healthcare. But even going before that, uh, when I was doing my PhD in 2008 to 2012, this was also the focus area of my research on how to come out or design a digital platform for India's primary healthcare, and that is where Professor Sasara is very helpful, along with Professor Anegawa from KO Business School, and also my professors in Tokyo Medical and Dental University. So broadly speaking, this is kind of a history recollection of what happened in the last 12 years. First, it started in Japan, and after 2013, we started the health informatics program here in Hyderabad. And this is part of Public Health Foundation of India, which itself was started in 2006, primarily to start public health education, training, research, policy advocacy. And we are now present all across the country, although the biggest academic division is in Hyderabad. And here we also look into public health and also into health informatics or digital health, which I'm kind of heading. So broadly, what we are trying to do is bring medicine, engineering, and design together, and to address the primary healthcare problems, which in a way are fairly unique to India. I mean, a lot of challenges that India faces are not really challenges that even any other country faces. So we need to really work out solutions of here. I'll give you an example. India is one of the only countries in the world which actually has 30 official languages. No other country has so many languages, probably one or two or maybe less than half a dozen, but no country in the world actually has 30 official languages. Now that itself presents a serious challenge in communication. So these are some of the issues that we are actually looking at and trying to come out with solutions and see how you can actually build a digital primary healthcare platform for India. So when you're talking about primary healthcare on a digital platform, there are two parts of it. One is the healthcare side, which is fairly globally accepted. But on the other side, there is the ecosystem, which I said is unique to India. So you need to find a solution that is fairly workable in India and also scalable across the world. So that again presents a twin challenge. Again, when we are talking about primary healthcare, it is not one solution or one service. There are actually multiple services that need to be delivered on the ground, and all of them, I would rather say, are equally necessary. Some people would like to prioritize, but I guess on the ground, each service is actually necessary. And this again goes back to some of the work that I did during my PhD. Where we systematically listed each and every service that need to be delivered on the ground, which is already documented in the public health standards. And you see that there are actually multiple services. There are at least 14 unique services, and each one again subdivides into a specific subdivision. So if you add up all these services, you're looking at least 1,000 odd microservices that need to be designed and developed and translated onto a digital health platform, which becomes a tremendous challenge in itself. And that's what we have been trying to do in the last hopefully 7 years. So if you again look at healthcare, there's fairly a very diplomatic definition as far as WHO goes, but that again is not something that you can actually make it work on the ground. So healthcare is fairly a complicated subject where you are looking at primary care, then home care, secondary care, tertiary care. But again, when you mean healthcare, it actually means a lot to different people. Some people think even wearing a Fitbit wristband is actually healthcare monitoring. That is really not true. I mean, it actually goes into the wellness side of it, but it is actually a segment within healthcare which falls into healthcare promotion. And then you have surveillance, which is high risk cases. And then you have diagnostics where people show some signs and symptoms. And then you have treatment. And then you have follow up. And all of this actually comes into healthcare. And with regard to specialties, there are actually 23 specialties. And then you have diagnostic products, finances. So you see that healthcare is a very complex matrix. It is not as simple as invented a thermometer and now we can change the entire healthcare. It's not as simple as that. So this becomes a real challenge, especially in a country like India, which is fairly resource constrained. And making all these things work on a digital platform is extremely challenging, to a point that very little actually works on the ground. And this is actually shown in this graph here. On one side, you see India, where the OP index is 0.4. On the other side, you actually see countries like South Korea or Japan, where the OP index is 12 or 13, which actually means uh, how rather how far we have to go to catch up with other countries. Indian primary healthcare system has to improve by 10 or 20 times if we have to reach what other countries are actually doing, and that's a huge jump that we need to come out with original solutions and actually make a jump. It's not simply like improving services by 20% or 30% or probably even 100%. We need to improve our services 20 times, and that's a huge what I call an order of magnitude. And this is where challenges, as I mentioned, like language actually come into play. So even if I make a innovation, translating it into 30 languages itself is a expense that is even bigger than possibly the money that I invested to come out with the innovation. So these are some of the challenges that need to be addressed in India. And if you even look at language as an issue, a lot of disease screening or probably even healthcare promotion happens in local language. So what we did was we were thinking, can we even remove language out of the equation? So we picked up all the healthcare questionnaires that are already developed and validated, and we identified all the keywords and converted them into icons. So now we have developed almost like over 1,000 icons for each of the keywords. And then we developed the software, which again we are working along with AKT to actually develop them as software. So this is what our software actually looks like. It doesn't have any text at all. So all we need to do is look at the icons and probably hit a plus or minus button, and our software will actually give a differential diagnosis but also further management. So this way we were able to address the issue of multiplicity of languages on the ground and still ensure a rapid, reliable way of screening and providing some kind of a healthcare advice on the ground. All these are experimental conceptual products, which will probably be soon pilot testing in the next 6 months or even less. So this is how we identified a issue on the ground and tried to address it with technology. Another fairly simple challenge on the ground is even identifying the height and weight of a person. Now, height and weight is fairly simple and easy to assess. All you need is probably a weighing scale and a measuring tape. But even these two things are not available in rural areas. And even if it is available, people simply don't carry them and do it in a way that it should be done. So again, here we actually came out with a computer vision based solution where if you take a photo of a person in profile, we are able to automatically identify the height, body width, and thereby we worked out an algorithm connecting these two weights. So instead of even using a weighing scale or perhaps a measuring tape, with a single image we are able to identify height and weight reliably at up to 85%. Now, what we are even further working on is to bring in nutritional advice that is customized to the location and to the person at the point of need. So this is again something that we identified as a challenge, and we came out with a solution that is at least about 40 to 60 times faster than an existing solution. So if you even add up the time it takes for you to measure height, weight, and then use your analytical skills to work out the BMI, compared to that time and compare it to the image-based solution that we have worked, our solution is at least 50 times faster. And those are some of the areas that we are actually working on. So once, hopefully, if these things work reliably, we can integrate it into a lot of our government health services, which people perennially blame them for corruption. But the reality is there is no reliable way to deliver services on the ground, which is what we are trying to address. Another solution that we have come out with was augmented reality based solution, again to assess disability screening at home. So again, there are solutions for other disability screening like visual disability, probably speech disability, but there is none point of care screening for physical disability, which is measuring the range of movement. So we have developed an augmented reality application, which is almost 95% reliable, where you can take it to a person's home and measure the range of movements and identify the percentage of physical disability. So here you see some of the photos where we are comparing it with our existing gold standard, which is a goniometer, and our application, which is fairly 95% reliable or even more. So we have raised support from Grand Challenges Canada and also google.org to make this reality. And we have actually developed an application, and as I said, field tested it. So these applications can be not only used for disability screening, but also for orthopedic, neuromuscular, and dermatological conditions. So here you see another example of our software that we have developed, a complete physical disability assessment UI, where you don't even see one single word. So all you person needs to do is load the software on a smartphone, and you can load hundreds or even thousands of them, and take it to the field and follow these icons and probably hit a plus or minus button, and you will be able to deliver services on the ground. And as I said, this is almost a quantum leap from what is presently happening, at least 20 to 50 times faster than what is available on the ground. And again, I'll have to put in a disclaimer, these are all fairly concepts that are not yet been tested on the ground but will be tested soon. So once you do this testing and screening, on the other side, there are the interventions. So these are all the interventions that the government says a disabled person can actually avail, but a lot of them actually don't reach the people. So here we are trying to link screening and the interventions in real time. Another application that we developed was three-dimensional reconstruction of the amputation stump. So this is the normal way of making a prosthesis. And what we actually did was we were able to recreate this 3D model of a stump with merely 10 to 15 photographs, that too taken from a mobile phone. So this way, we were able to reconstruct this entire amputated stump that was almost 99.5% accurate, which means you would be able to work out a prosthesis that is actually a custom fit to this person's stump, and that way it will be much more convenient and comfortable. So what we also did was we took a photo of the other side of the limb, or the other limb which is normal, so that we'll be able to build a prosthesis that actually looks like the person's limb, and ensuring much better compliance and a little bit more happiness to the person who would be actually wearing it. So these are again challenges that we identified and greatly reduce the time and complexity in building solutions. Yet another application that we developed was with regard to dermatology. I guess the first speaker was showing about application for mole. So here you are relying on fairly high-powered cloud-based computer vision algorithms. And what we tried to do was make them a lot more simpler. So what we added was a few of our icon-based questions. And excuse me. So that if you actually ask a few questions, less than half a dozen of them, we are able to reduce the number of diseases that you are screening from 30 to 50 to less than 3 to 5. And then we ask the person to take a photo and then identify what is basically the abnormal area. And we found out that the edge computing based algorithms are almost 96% reliable compared to regular algorithms, which are fairly reliable up to 70 or even 80%. So this is again a challenge that we identified and probably came out with a working solution. Again, another challenge that we identified was the screening of uh, people with depression. So here we came out with a again mobile based solution where we were able to identify if the person was depressed or not by not even asking a single question, but by simply tracking his passive data that is generated out of a mobile phone, which is the number of calls that you make, duration of calls, time of calls, frequency of screen ons, and your activity rate. And we are able to clearly separate a person who was depressed and not depressed. And again, this was published in JMIR. A lot of our work is again proprietary, and we are yet to publish. We are actually applying for patents, but this was work done in association with a startup. And this startup actually pivoted this idea and turned this application into an engagement tool, which is now being used by over 3 million people. It's called as, I think, no, I think I just forgot the name of the application. Yeah, I think it's called as Visa. It's available on Google Play Store, and then you'll be able to download it. So it's now used by 2 to 3 million people across the world as a companion tool. So it actually detects the level of depression and tailors the conversation automatically, and it's pure AI that is actually involved. So this is how the chatbot actually looks like. My team was also the first one in this country to deliver a box of medicines strapped to a drone. And we are actually working on furthering this idea where we are conceptually trying to come out with a drone that can fly for 200 to 300 kilometers and carry a payload of about 50 to 100 kgs. And that way we will be able to come out with a complete logistic system that not only carries medicines but also diagnostic samples back, delivers vaccines, connects blood banks, and also helps with the organ transport. So this will be a complete drone based comprehensive platform for healthcare, which is something that we are working on. What we also found out was when people talk about drones, it's usually considered expensive and exotic, but we actually came out with the numbers which showed that drones actually can be an economical way of connecting these health systems, simply because the government is actually spending a lot on the ground, which is not properly utilized. So here you see blood banks, each of them that cost about like $1 or $1.5 million or 7 to 10 crores in Indian currency. And you see that there is not a lot of blood available in all these blood banks. So, and that's because of various challenges on the ground and the fact that in a lot of places people are not even willing to donate blood. But on the other side, there is excessive blood that is available in certain blood banks, which has to be utilized within a short period of time. So if you are able to use drones to connect these blood banks, we see that it is actually a much more optimized way of even utilizing those 10 crores that I already put on the ground. And that way, even if I pay a crore or possibly a quarter million for a drone, it's actually a force multiplier for the existing investment that is already done. So that way we see that drones are actually economical. And after we proved that this is an economical way of delivering healthcare logistics, we saw bigger companies showing interest, and Boeing also sent a team so that they can actually go around the healthcare facilities and see if we can actually build a use case for drones. I think just give me a second. I'll come back to the appropriate slide. So here what you see is we have actually mapped each and every village in a district. So there are almost about like 700 villages, and you see all those black dots. So each and every village has been mapped. And also each and every healthcare facility has been mapped in one district of 1.5 million people. So this way we were able to put a circle of around 20 kilometers around it and showed that there are a lot of clustering happening around in the healthcare system. So this is again a case for AI optimization, where automatically we are able to figure out which is the best location to set up a healthcare facility, or probably readjust the existing facility in such a way that it can actually serve the entire population without any kind of a gaps. Again, these are suggestions that we actually give to the government. Apparently it's up to the government to take it or not, but these are some of the initial steps that we have actually made with regard to using computer vision or even like GIS based optimization to almost redesign the way Indian healthcare system could potentially be delivered in the near future. In the interest of time, I'll just quickly glance through a few slides. So here we have a representation of the health system in a district, where in the middle you have the district hospital and the primary healthcare systems around the sub-centers and the villages around. So what we have even proposed was, instead of having multiple facilities per district, using drones, we will be able to consolidate everything and make it a lot more simpler and make it even more economical also. So these are some of the cost economics that we have actually arrived at. And this is a representative model of the drone that we are even proposing. So this is the team from Boeing that we actually hosted and took them around to primary healthcare centers and district hospitals. And as I said, getting data on the ground or from the ground is extremely challenging. So this is how data actually lives in India. It's not all on an Excel sheet or not all on a computer. So we have to go to the field and then literally screen each and every case sheet or each and every register. And we actually took almost 50,000 photographs in one district, which is a huge resource that we have been still working on. But that kind of data is what gives us a very good base to even make our assumptions or probably even make our recommendations. So here you see all this clustering happening and all the unoptimized way health services systems are even spread out. And the optimizations, the routing and optimization that we actually worked on. So this is again something that we take it for granted when Google shows us the way, an optimized way or the shortest way to go to a destination. But when you are actually starting to do things ground up, there's a huge load of data that needs to be generated, all from a very remote and probably even a hard to reach location. And only when we have this kind of a comprehensive data, we'll be able to come out with solutions that can change our healthcare. So again, here we see an example of our Arogyashri program. This is the Indian health insurance program, where you see that even after 10 to 15 years of implementation, a lot of remote villages don't even have one single beneficiary. So again, when we visualize this data in such a way that it is easily understandable, it becomes a lot more easier for people to understand. So again, data visualization is a key area that we are actually working on. So visualizing the Arogyashri data, you see that although it is widely used, only 2 or 3 specialties take up much of the cost of the program. So here you see that only cardiac surgery, then genitourinary surgery and polytrauma literally takes up almost more than 50% of the expenses involved with the program. Again, it's much better shown in a visual way. Then the government will be able to reallocate or probably set up new facilities, which is what is actually happening. So these are the distributions of the healthcare facilities in one state. And again, you find that there are actually a lot of gaps and clustering. And the moment you start visualizing and using optimization algorithms, you'll be able to either redistribute or set up new facilities across the state, leading to better healthcare. So that is on the state level. So on the other side, we have actually gone to almost like 100 villages, to each and every household, taken a photograph of each and every household, did a household level screening, and we are trying to put them onto a digital platform. So here you see an example of one village which has about 36 odd households, where we are able to take a photo of each and every house. And now we are using AI algorithms to automatically identify the type of house also, whether it is a thatched house or whether it is a brick house or whether it is a pucca house. So these are some of the data sets that are not available anywhere in the world that we are trying to generate, and also use AI algorithms to come out with solutions that can be scaled up and used globally. So here in one village, we see very precise way of identifying who is undernourished or not. Again, the first speaker was actually speaking about precision medicine. So here we are taking it all the way to a person's household, and then even identifying who is undernourished, who is sick, who is disabled, so that we will be able to provide a targeted benefits or targeted guidance in the near future to that particular household and that particular individual, and we'll be able to monitor and track at a individual level. So these are some of the visual examples that we are actually working on. Again, these are fairly large scale projects, meaning we actually reached out to 120,000 people in 100 villages. But this was so impactful that now we are actually starting up another study all on a digital platform to reach out to 1 million people, and that would hopefully happen in the next 3 to 6 months. So this is a larger village with about 1,000 households. So it's an example where we even larger villages can potentially be mapped. And once you map, you can actually recreate all these things on a digital platform. So what you see here as gray boxes are houses, the lines are roads, the blue ones are the water ponds, the yellow ones are the open defecation areas. And once you have all on a digital platform, you'll be able to track them and see how things are actually changing even little by little. Again, the speaker before was actually talking about micro changes, incremental changes. All those things could actually be tracked digitally. So those are some of the things that we are actually trying to do on a fairly large scale with 1 million people. And once you do that, you find that not all the villages have all the diseases. Only a few of them are have some diseases. And that way we'll be able to work out routing mechanism where you send a healthcare worker who is properly trained to address a few diseases, so that he actually goes directly to the house where they are suffering from and probably give them interventions, and then take care of the people in a much better way, rather than the present way the government is actually spending on health systems, where all the health systems look very similar, and it really does not address the need on the ground. So a lot of these things could potentially happen better on a digital platform. So broadly, this is what my lab is actually working on. Primary healthcare system at the moment is not accessible. What we are trying to make is make it accessible. But for that, we actually need solutions that are 10 times, 20 times faster. Each and every solution has to be 10 times, 20 times faster. So we have listed all the solutions, and we are coming out with interventions that are 10 or 20 times faster. And I've given you some of the examples, and these are fairly limited examples. There's more work that is actually happening on. So we have called our platform as myth.ai, which is in short for mass integrated transformational healthcare. And again, there is a website which is called as myth.ai. You should be able to have a look. Very limited information is available, but when we actually roll out a large scale trial on the ground, we'll be adding up further information. And we are also trying to set up a commercial division and hopefully take things forward in a much faster way. So these are some of the solutions that we are actually trying to work with, the findings that we have had on the ground. On the left side, you see a handheld device that we have developed, and you see software with very little text in it. And then you also see a two-wheeler based platform which has all these vaccines, medicines, where on one side you'll be able to screen, and on the other side, immediately you'll be able to treat if there is any kind of a necessity. So as a comprehensive unit, we are using AI in the background to not only screen but also deliver interventions all at the doorstep of a person. A lot of technologies is there on the background. It's not only AI, but our applications or our focus is more on the services and more on the front end. And basically, we just use any technology that actually works. So broadly speaking, what the outputs that we are working on is we want to deliver primary healthcare at the person's home. We also want to make sure that it is comprehensive, but also delivered in real time. And that is what we are actually trying to work. And we do have a working prototype at the moment. And as we go forward, we'll hope to convert them into working services and hope that they actually transform the primary healthcare of our country very soon. So these are some of the people who actually visited. I mean, you see Professor Srinath Reddy, who is the president of Public Health Foundation, and also the other person in the image is the head of London School of Tropical Medicine. He also came and visited us. And we recently signed a MOU with Intel and Telangana state government to roll out the large-scale pilot trial. So this is the image of the inauguration. And Professor Sasar also visited my lab, and also the head of healthcare architecture of Microsoft also visited my lab recently. So we are trying to build an alliance and take these ideas forward. So thank you for listening, and I guess I'm just stopping right in time.
Thank you so much, Dr. Suresh. We actually do have a few students in our participants. I'm sure this wonderful work of yours, they would have been motivated to get into this field. We have one question. I think it was on the Visa app. Let me just check if I can.
Yes, I'm seeing the question. Yes, it is by Touchkin. We actually jointly published a paper by them.
Yes. Sir, there is another question. Any strategy to diagnose cognitive impairment remotely?
So, relatively speaking, cognitive impairment, if it is congenital, it is fairly easy to diagnose. I mean, you are going to see the signs and symptoms fairly straightforward. So again, as I said, we are actually developing these signs and symptoms as icons, and we will be able to take it to the person's doorstep, and we'll be able to do the screening and diagnosis. What will be challenging is the intervention part. Now, I mean, those are areas that we need to work on. Screening is possible, and probably diagnosing may be possible, but getting interventions to the person's doorstep is possible up to a first grade of disease or the early stage of disease. But certain diseases again are very difficult to modify, and that would require a lot of work, which is still work in progress.
Yes, I think that was one. There was one last question again on the Visa app. Is because the Visa app works on data of the user's uh, history on the mobile, the browsing history, etc. I think that was mentioned. So, uh, first question is: does this app? I mean, where to what does this app report? And second is on the data security.
uh, Visa does not actually ask any store any data from the mobile phone itself. In fact, it was one of the challenges of the founders, where if you take in the data, you have a much business case, but they decided not to collect any data from the phone. So it does not even know where you are actually, logging into. The entire response from Visa is primarily based on the chat that we are actually typing into the software. So if we kind of type in sentences, the AI algorithm picks up the mood of the person who is typing in from the sentences that he or she is typing, and delivers the response based on the sentences. So we are actually giving data uh, as our chat to Visa. Not other data is actually not collected. Data security is a universal challenge. It's not necessarily related to Visa. And there are several ways to address data security, one of which is making sure that we don't actually give unnecessary data by reading through all the small text that most of these developers actually give us. So that's the first thing. The second thing is the way data security is done on the backend side. One way is to host the data in multiple servers in parts, so that if the data is hacked, nobody has access to the entire data set. And also the other way is to kind of de-identify them and bring them together at the point of need only when you are actually using. So again, if one part of the data is hacked, without the identifier, you wouldn't be able to understand what exactly the data is. So there are a lot of steps which you can actually do to improve data security at the for these digital solutions. But what we also need to think when we start fearing about data is also other side where people actually rely on all these digital solutions. They actually have faith. So fear and faith is going together. A lot of people who believe that these digital solutions are actually working. So in the name of data security, we should not throttle or basically put too many obstacles in the way forward where digital solutions do not even go forward. So we should have a balanced approach where digital solutions help a lot of people. It may have some challenges, but that is again the issue with all technologies. There's a lot of benefits coming out of it, and there are some challenges that we need to address them step by step.
Absolutely, sir. One last question for you. There is our participant, Mr. Mastan, who wants to know how he can join you in helping with the outstanding work. So is there any way, if someone's interested, they can reach out to you?
That's very easy. I think you can just share my email ID or my phone number.
Okay, sure. So, Mr. Mastan, we'll do that. We'll share Suresh sir's email ID with you. Thank you so much, Dr. Suresh. I think it was such a wonderful session. The
Sure.
participants have enjoyed it immensely. Thank you so much.
Thanks, Rashmi. Yeah, thank you.
Thank you.